welcome to the 4M seminar series. I'm Dr. Gemma Sharp and I lead the 4M Consortium, where the 4Ms are menarche, or the first menstrual period, menstruation, the process of menstruating or experiencing a menstrual cycle, menopause, the last menstrual period, and mental health, which we define as a complete state of well-being that allows an individual to enjoy their life and realise their potential. 4M is a consortium of academics working to understand the complex links between female reproductive and mental health. We facilitate collaborative, interdisciplinary research that aims to develop a better understanding of the biological, psychological, social, and environmental mechanisms that link female reproductive and mental health, and how interventions can effectively target those mechanisms to improve the relationship between female reproductive and mental health. We host this free seminar series to help share our research with each other and the public, and to hear from a wide range of voices outside of 4M. We hope this will help inform both 4M members and others about different perspectives and how new research findings are influencing the field. This month we have a talk from Dr. Jackie Maybin from the MRC Centre for Reproductive Health at the University of Edinburgh. Jackie is a world-leading expert researching menstrual health and a practicing gynaecologist. At the start of her talk, she explains a little bit more about what that means. She then goes on to define typical menstruation and problematic menstrual bleeding. She evaluates current medical and surgical treatment options, and she illustrates active areas of research to improve diagnosis and treatment. I really hope you enjoy this seminar, and if you do, then please like and subscribe on YouTube. You can also follow us on Twitter at 4M Health and sign up to our newsletter via our website www.4mhealth.uk. Thanks.
I spend 50% of my time running specialist menstrual disorders clinics, where we offer medical treatments, minimally invasive surgical procedures, right through to large abdominal hysterectomy type procedures for patients suffering from menstrual problems. The other 50% of my time I spend coordinating a laboratory research programme, and I have great members in the team from across different disciplines, with the kind of ultimate aim of developing better preventative and therapeutic strategies for people who we see in clinic. So, I mean, I think I've one of the best jobs in the world, as I suppose everyone in the room probably thinks they have too. So it's lovely if we can all work together to try and move this area forward. I'm just going to start with a quote from a patient who I have permission to use this quote. It's a patient who came to my clinic and needed a number of interventions, including blood transfusion. And I'll just give you a couple of minutes to read through it, because I think it's quite a powerful quote, and one that I'm sure will resonate with many in the room. It really struck me that the impact of her menstruation and the things that she found really difficult were not the physical aspects of needing blood transfusion and multiple surgeries, but the impact on her life. And it also struck me that she was very clear that she wanted to be anonymous in the quote. And I think that really highlights the taboo and the shame that surrounds menstruation. And I know many of you here are working on those more social and psychological aspects of menstrual problems. And I hope that this, if you can take anything positive from a quote like this, it reassures you that the work you're doing is incredibly important. But she's not alone with this. I think lots of people find it very difficult to talk about periods, and it means that from a medical perspective, at least, it means that if we don't know what normal is or what typical is, it's very difficult to seek help when needed. And although I see many women in clinic, I'm aware that it's probably the tip of the iceberg, and there's many more out there not getting the help that they need. So our laboratory sat down to write a mission statement, and we're currently reviewing this. If you haven't done it as a research team, I think it's a really useful thing to do. But we came up with this statement about what we're aiming to do in the lab. And really, it's all about collaborative research and working together to try and improve the quality of life of those who menstruate. I will, during this talk, use women a lot. I mean that in the most inclusive way. It is a natural fact that most of the people I see in clinic are women and identify as women, but I know that many people who don't identify as women can still suffer from menstrual problems, and I acknowledge that many women don't menstruate, so I mean that in the sort of most inclusive way throughout the talk. So just as a quick run through, I want to give you some definitions, medical, I suppose, definitions of what typical menstruation is, and then try and define what really may constitute problematic bleeding, because we can't do the second without the first. But I really want to spend most of my time looking at the medical and surgical treatment options for problematic periods and highlight some of the ways that we can, as medical professionals, try and improve the diagnosis of the underlying cause of the conditions, and ways that we're working within the laboratory to try and develop new treatments. I've kept it quite general and hopefully quite accessible, but I can signpost extra details for people who want it as we go through. So what is typical and what is problematic? Well, firstly, what is menstruation? Everything in the body is controlled by the brain, pretty much, and the brain signals to the ovaries to produce estrogen in the first half of the cycle and very high levels of progesterone in the second half of the cycle. So estrogen really encourages proliferation and development of the lining of the womb, the endometrium, to prepare it for pregnancy. And once an egg has been released from the ovary, the corpus luteum then produces progesterone, which really fine-tunes the endometrium so that an embryo can embed if fertilization occurs. But in terms of menstruation, it's this fall in the ovarian hormone levels at the end of the menstrual cycle that really is the trigger for menstruation, and particularly the decline in progesterone. And that causes a huge inflammatory response within the lining of the womb. And if we look with a hysteroscope at the time of menstruation, when you look in, it's very red, very raw. You can see active bleeding. It looks very much like a wound, and this completely repairs for the next cycle. And it's this complete restoration of the endometrium that really is quite fascinating. But there's a huge amount of inflammation at the time of menstruation. The blood vessels all constrict, and there's some very low oxygen levels within the lining of the womb. And we think that that triggers the repair process that is necessary to stop bleeding and to allow implantation in the next cycle if that's what a woman wishes. So what is typical in terms of menstruation or periods? Well, a group of experts sat down over 10 years ago. Well, yes, it probably was 2011. It is over 10 years ago, and really discussed how we should assess menstruation, because people were doing different things in different countries in different ways, and it was very hard to standardise both research and clinical data. So they came up with 4 parameters, which are really quite quick and easy to assess. The duration of a period is the amount of days that you bleed for, and typical is anywhere between 4.5 days to 8 days, the half day being because it's a research-based number. I don't think many women would come in reporting half days, but anywhere between 4.5 and 8 days is considered within normal limits. The frequency of menstruation is the number of days from the first day of one menstrual period to the first day of the next menstrual period. And this can vary a lot between different women, and anywhere between 24 days and 38 days would be considered within the normal range. Regularity then is the amount of variation in that length of cycle. So within the same woman, there's a lot of variation over the course of a year. And if you're, 28 days one month and 30 days the next month, that is perfectly normal. And actually less than 9 days variation, it's a bit age dependent, but less than 9 days variation would be considered perfectly within normal limits. The volume of menstruation on a research side of things is between 5 and 80 mils per episode of menstruation. what comes out during menstruation is not just blood, there's other factors and secretions in there as well, but between 5 and 80 mils would be considered normal on a research perspective, but you know, a woman at home will not give you the amount of mils that she's losing. And really what's more important is how manageable someone's period is. So what about when things aren't typical and do tip into problematic? Well, we hear a lot in clinic about people having prolonged bleeding. It bleeds for over 8 days is considered too long. Frequency can be, periods can come too often or not come often enough. Too often is what I hear more in my menstrual disorders clinic, but not frequent enough would be quite worrying for someone if they were wanting to get pregnant, for example. Regularity of periods, if it's very unpredictable and coming at different times, it can be very difficult to manage menstruation, and people get caught out at work or at school or at other times. And that can be really problematic for people if their periods are unpredictable. The issue of sort of heavy menstrual bleeding was spoken about already. That could either be objectively measured, which is more done for research, or subjectively described by the woman who comes in. And I think that's much more relevant. So just to speak a wee bit more about heavy menstrual bleeding, because that's a particular interest of mine and trying to get better treatments for people. I did a lot of work during my PhD and ongoing to quantify blood loss by collecting menstrual products and actually measuring blood loss. And we know that if women lose over 80 mils of blood per cycle, that they can become anemic. It's the equivalent of giving a blood transfusion every month, and it can make people feel absolutely rotten. We had measurements of over 700 mils in one cycle for some women, which necessitates blood transfusion because it really does drop the hemoglobin very significantly. But apart from the sort of those physical aspects, you know, heavy menstrual bleeding affects all aspects of women's life, affecting education and all the knock-on financial impacts of that, or work or caring roles that people may have. So more importantly than the objective measurement is what's acceptable. And this varies from person to person. The woman on the left of your screen may be able to cope with maybe 60, 70 mils of blood per cycle if she was working from home and has access to a toilet and good facilities. But the women in the middle and the right of your screen, you know, perhaps even 10, 20 mils may be too much for them because it's very, very difficult to manage. So the NICE definition of excessive menstrual blood loss is, I think, very all-encompassing and much more useful. If it's affecting any of your quality of life, can be alone or with other symptoms, then I think we should have tools to treat that for women who want it and require it. So in terms of how common menstrual bleeding problems are, I hear over and over again that menstrual research is quite niche, but 50% of the population are female, and 1 in 3 women have described having abnormal uterine bleeding at some point in their reproductive lives. So 1 in 3 of 50% of the population, I think, is a huge number, and I also think it's an underestimate. I think for all the people that are mentioning it, other people are perhaps unaware or not coming forward about their menstrual problems. It used to be that women were pregnant or lactating for a significant proportion of their lives. And, you know, looking back in history, women were expected to have about 40 menstrual cycles in their lifetime. Women in developed nations today are expected to have about 400 episodes of menstruation. So you can see that with leaving childbearing to a later age and the decreased age of menarche, these problems are only going to become more common over time. So I don't think there's any argument that these problems are very prevalent in society. So I want to just spend most of the seminar looking at the current medical and surgical treatment options. And I'm just going to talk you through what we have in our armoury if someone comes to the menstrual disorders clinic. We often split the treatments, the medical treatments, so you know, things that aren't surgical, into hormonal and non-hormonal preparations. So the non-hormonal medications that we can use are non-steroidal anti-inflammatories, so something like mefenamic acid or ibuprofen. Can be really useful to take just at the time of a period. And it's quite evidence-based that women with heavy menstrual bleeding have an increased amount of inflammation in the lining of the womb at the time of menstruation. And I told you that progesterone withdrawal causes a huge inflammatory response. And if that goes out of control a little or is too much, then people can experience heavy bleeding. So taking some anti-inflammatories just at the time of a period can put that inflammation back into a more physiological level and reduce blood loss by perhaps 10 to 20%. So it can be a really simple but effective treatment, though if people are experiencing very heavy bleeding volumes, then it's not quite enough often. Tranexamic acid is another non-hormonal preparation that is taken just at the time of menstruation rather than right throughout the cycle. And it's an antifibrinolytic. So I guess the way it kind of works is to cause the blood vessels to clot off that wee bit quicker as the lining sheds. So where the blood vessels are damaged, and usually blood is coming away with the lining of the womb, this just helps to block off those vessels so that the lining still sheds, but there's less blood associated with it. So these are quite useful for people, particularly if they're wanting to conceive. As I say, if people are experiencing very problematic or heavy bleeding, then that's not normally quite enough, and we tend to have to move on to more hormonal preparations. These act to sort of, in a way, override the ovarian control of the lining of the womb and try and keep the lining of the womb thin so it's not building up throughout the month. In a very oversimplified manner, it's kind of the main way that they work. They could be in the form of a combined contraceptive pill that people use for contraception. It can take away about 40% of your menstrual loss. Or it can be what we very commonly use for heavy menstrual bleeding is the Mirena intrauterine system, or the levonorgestrel intrauterine system. And it's a intrauterine device, so a little device that sits inside the uterus, keeps the lining of the womb thin, and can take away up to 90% of menstrual bleeding. So it's a very effective treatment, though doesn't work for everyone and is not wanted by everyone. The tablets, the norethindrone tablets there's different tablets that are sort of synthetic versions of the progesterone hormone. And if you take those on a cyclical basis, 3 weeks on, 1 week off, they can limit the amount of blood loss that is coming away with the period. And it works in a similar way to the Mirena, but in a tablet-based form. And the injection is the contraceptive injection, Depo-Provera. It can cause a lot of irregular bleeding, but in about 50% of people, it will take periods away completely with continued use. So it can be a good option for people who really don't want to have periods. So we sometimes use that as a treatment as well. But the big issue with hormonal preparations is they affect fertility. So if somebody's wanting to conceive in the near future, it's not really a feasible or desirable way to control menstrual blood loss. And the hormonal side effects can be really troublesome for a proportion of women. Some people notice hardly any, other people get terrible side effects. And these are just some of the progestogen side effects that people may experience. And I hear from a lot of people I see in clinic that they do not want to have these hormonal side effects from something that they aren't really needing for contraception anymore because their partner's had a vasectomy or they've been sterilised, they didn't want to use hormones, and then they're having to start using them to control their menstrual blood loss again. So it's very frustrating for people. So many people do proceed to surgical management. I do have some medical sort of images coming up, so please do turn away if you're a little squeamish. They're not very bad, but just as a slight warning, I get a little desensitized to these things. But this is a sort of cartoon of an endometrial ablation. So this is where we insert a little device through the vagina. It can be done awake or asleep under a day case procedure. This little wand opens up inside the uterus and it uses radio frequency ablation to destroy effectively the lining of the womb. So the signals are still coming from the brain, signaling to the ovaries. The ovaries are still producing all their normal hormones that you need for your bone health and heart health. But the lining of the womb isn't responding. It's not building up and shedding on a cyclical basis. The aim of this procedure is to make someone have no periods at all after it. That isn't always the case. There is a 10 to 20% failure rate with the procedure, so some people get hardly any benefit from it. That being said, 80 to 90% of people get a really good benefit from it, either with lighter periods or no periods after the procedure. It's not suitable for people who have abnormal anatomy. So large fibroids, for example, wouldn't be appropriate for people experiencing heavy bleeding due to that. And it is dangerous to get pregnant after a procedure like this. It's not contraceptive, so people can get pregnant, but it's very dangerous for the mum and the baby. So good form of contraception is required if people are using this. Again, I've said there's a failure rate with ablation, or some people opt to go straight for hysterectomy, and this procedure can be done as a keyhole procedure, which are the images on the top of the right-hand side of your screen. This is the womb that's been, the ligaments and the blood supply have been taken away, and what we do is take that uterus and it comes out through the vagina, and then you can see at the end there's been a stitch put across the vagina in the centre of the picture there. Both ovaries are conserved. They've got their own blood supply and they can be left behind to supply all the hormones that are needed. But when the womb comes out, then we guarantee that they won't have any periods after a procedure like this. The two pictures in the bottom of your screen show an open hysterectomy, so a traditional hysterectomy, and we would still do an open hysterectomy for people with large fibroids where the womb's just too large to take it out through the vagina. So this shows a uterus here, and this is where the bladder would sit right in front, and we've pushed the bladder down, so there is a small risk of bladder injury with these procedures. And you can see in these pictures here that the bowel is very close by to where we're working, and there's a small risk of damage to the bowel during hysterectomy procedures that we always counsel people about. So it's not an insubstantial operation, but the bonus is that we can guarantee that people won't have any more bleeding in terms of menstruation after a procedure like this. But with both of these things, fertility again is a huge issue. So if somebody's wanting to preserve their fertility, these are completely ruled out. So they're not even an option for people who want to have children either now or in the future. So really, when it comes down to it, I think we need to get better at personalising our treatment for heavy periods. We need to think about what the user is wanting from their treatment. You have to think about safety, and you have to think about the preference that people have, and the method that they want to use, so that they're, if they don't use it, it definitely won't work. So all of these things have to be taken into consideration. And I think if you ask any woman in the room, she'll tell you that one size definitely does not fit all when it comes to dresses or any treatments for heavy periods. But we have to make sure they're effective, and we need to make sure that there's minimal off-target effects and that people don't experience terrible side effects or any issues in terms of safety for other parts of their system as well as just the reproductive system. So I want to spend most of the time now at the last bit of the talk just going through how we can get better at this, and how we can improve the diagnosis of menstrual problems and improve the treatments that we offer to people. And I want to just talk you through a wee bit of what we're doing to move this area forward. So for me, I think heavy menstrual bleeding or abnormal uterine bleeding, be it irregular or any of the different problems that people experience, it's a symptom. It's what people tell you about. It's what they experience, but it's not a diagnosis. It's not the root underlying cause. So if someone has heavy menstrual bleeding, there could be a number of things causing that. But previously, I think what health professionals have been doing is they've been treating the symptom and not looking for the underlying cause. And to me, that's a bit like pulling up a weed without getting the roots. It may temporarily help, but inevitably it will grow back, sometimes stronger. So I think what we need to do is sort of shift away from treating symptoms and start treating the underlying cause and getting more specific and more personal about the way that we tackle the problems that women are experiencing. So again, the international group did do some work about helping us come up with a sort of plan for the underlying causes that people may have, and they split these into structural causes and give it the abbreviation of PAM, and non-structural causes of COIN. So if thinking about a PAM sitting in or a coin sitting in the palm of your hand, that gives you a structure for remembering all of the different causes of abnormal uterine bleeding. So the P in PAM is for polyp, and that's a little outpouching of the lining of the womb. So this is a scope looking through the vagina, through the cervix, and into the inside of the uterus. This is called a hysteroscope, and this you can see in the picture on the right. This is a little polyp, and that can cause very irregular bleeding. So we tend to get a lot of bleeding in between periods. The A in PAM is adenomyosis. So this is a condition where the lining of the womb is found embedded within the muscle layer of the uterus. And I've told you already that progesterone withdrawal causes inflammation and bleeding, and those little bits of the lining that are within the muscle layer of the uterus will also respond in exactly the same way to that hormone withdrawal. So they bleed, they become inflamed, and that causes sort of a bulky womb, so the womb tends to get a bit bigger. And can cause some pressure symptoms and cause very heavy, painful periods, as you can imagine, if that blood is trapped within the muscle layer. Leiomyoma is the medical term for fibroids. So fibroids are an overgrowth of the muscle layer of the uterus. So it's like a knot in the muscle. I often describe it as, you know, those balls of elastic bands that people have in offices. It's a little bit like that. They can be anything from sort of tiny, sort of less than a centimetre, right up to like 20 centimetres. People can look very heavily pregnant if they've large fibroids. But depending on the size and the location of fibroids, they cause different symptoms, be it pressure or heavy menstrual bleeding or constipation. That kind of thing can go along with it too. But these fibroids, particularly on the inside of the womb, it is like a tap is being turned on when someone has their period. People often describe it, my period starts like somebody's turning on a tap and I just flood everywhere. When I hear that description, I'm thinking, I think this may be due to fibroids, and those fibroids specifically on the inside of the womb. There's also cancer that we need to look out for if somebody presents with bleeding problems, and that needs to be excluded. It's not the case in a lot of women, but we definitely don't want to miss cancer. So we always check if someone needs a check of the lining of the womb to make sure it's not cancerous. And with it being Cervical Cancer Awareness Week, you always check the cervix and the vagina and the vulva indeed for cancers. So if people come through, that they would be the safety checks that we would do. But there's sort of red flag symptoms that would make us worry about that, and that's a lot of bleeding in between periods, or bleeding after sex, or bleeding after the menopause. Those are the times that we would definitely want to check for these kind of cancers. So all of these structural causes are usually detectable on an examination or by ultrasound scan. There's usually something to see, and that can be really useful in making a diagnosis for the specific cause of heavy bleeding. And ultrasound scans can be really useful for that, because then that can tailor the way that we treat these. And these structural causes are often slightly less responsive to our medical treatments and our hormonal treatments, and often more likely to respond to surgical interventions. So it's really important to diagnose them and then tailor the management so that people aren't using repeated hormonal treatments and none of them are working. Really, we should be checking for these kind of structural causes to see if there's a more specific way of treating the bleeding problems. And to show you that, I just want to show you this little video. So these are the pictures from the hysteroscopy and the little polyp that we saw. On your right, this is a video from Hologic, who make the device that you'll see being used here to remove the polyp from the uterus. So this is again through the cervix, inside the womb, and you can see the little polyp coming from the back wall of the womb there. And this little device cuts as well as sucks. So it lifts that polyp, removes it completely, and we can send off the polyp to the labs to get it checked to make sure that it is completely non-cancerous, which we do as a routine. And this means that the woman has the direct cause of her abnormal uterine bleeding treated within minutes, instead of using multiple different hormonal preparations for the rest of her reproductive life. I mean, this is a really easy fix, and that's why we need to diagnose these problems so we can fix them properly. So the non-structural causes then, that coin sort of side of things, these are things that don't really show up on an ultrasound scan. So the anatomy looks completely normal. And people with menstrual disorders who get a normal scan can be very disappointed, but about 50% of people don't have a structural cause that will show up. It doesn't mean they don't have a root underlying cause, it just means there's nothing structural there. So a normal scan, sometimes they feel a bit disappointed that they haven't got a reason for it, but it just rules out 50% of the causes, and then the rest of the causes won't have anything to see on an ultrasound scan. And these are things like bleeding disorders. So von Willebrand disease is a condition where you bleed too much, and about 10% of people with heavy menstrual bleeding actually have that as the underlying cause. It's really important to know that and test for it, because the treatments are very different, and you can use specific correction of the clotting defect and replace factors that these people don't have, and that really helps with not only their menstrual bleeding, but if they're attending the dentist for a tooth extraction, etc., they won't experience a hemorrhage at that point too. Ovulatory dysfunction, clearly the ovaries are producing the hormones that regulate the lining of the womb, or the endometrium. And if they go off kilter, then the lining and the response of the lining will be dysregulated too. So times when you don't get that really regular release of an egg once a month, that tends to be more common at the start of reproductive life and at the end of reproductive life. So there's lots about the menopause at the minute, and people experiencing bleeding problems around the menopause. And that's usually due to the fact that the ovaries are running out of eggs and maybe only releasing one every other month. And that knocks things off. The lining builds up a bit more. There's more bleeding that comes away whenever they eventually do get a period. The other condition that would be placed in this category would be polycystic ovary disease or disorder that can affect the release of the eggs from the ovary and mean that periods are infrequent and often very heavy and problematic when they do come, or indeed the opposite, very frequent because there's no regulation of the shedding. So those are the sort of disorders that become under ovulatory dysfunction. Again, that usually presents on questioning as very irregular periods and problematic periods. And that is, that going through with a woman, the kind of pattern that she's got means that you can tailor the treatment again. And these do respond very well to the ovarian or to the hormonal preparations that we've got, because it's really at the level of the ovary. So therefore, you're specifically treating not necessarily the underlying condition, but at least at the sort of same level. So these do respond very well to the Mirena, and sort of contraceptive pills and that kind of thing can be really helpful for that group of people. Endometrial disorders are really, we call it a diagnosis of exclusion. So if you've ruled out everything else, then perhaps the problem is that there's something macroscopic going on or microscopic going on within the lining of the womb as it's being shed. And this is where I have a real research interest. We've already spoken about the excessive inflammation that some people have. Some people don't get the vasoconstriction, so the constriction of the blood vessels. And if your blood vessels don't narrow, then you get more bleeding, and also you don't trigger the repair process. But so immature blood vessels, too little hypoxia, where you're meant to have low oxygen levels to trigger the repair, it maybe doesn't happen. These do respond to ovarian or to the hormonal preparations, but it's a bit like cracking a nut with a sledgehammer. And, we're hopefully trying to develop more specific treatments rather than overwhelming the whole reproductive system with the hormonal treatments, maybe just correcting the specific defects. So I think there's a lot of work to be done there in improving things. Iatrogenic is the word we use for whenever we give people something as medical practitioners and it makes it worse rather than better. So things like the Mirena can be really useful for treating heavy periods, but 20% of people won't respond well, and they're very sensitive to the hormones and they get a lot of irregular bleeding. I think we need to remember that what we are doing to sometimes help can actually cause problems, and if that's the case, given time, sometimes it settles down, but if after 6 to 8 months of use of the Mirena, the bleeding profile is still pretty shockingly bad, then it's not right and should be changed for something else. Warfarin is an anticoagulant that we use if people have had blood clots in the legs or the lungs, life-saving treatment, but can, as a result or a side effect of that, cause heavy menstruation. We can't often stop these preparations, but there's some that are better for menstrual blood loss than others, so they can be tweaked. And sometimes we need to use treatments alongside the anticoagulants to manage people's periods. And then not otherwise classified really encompasses Endometriosis is placed in there, I think primarily because the major symptom with endometriosis is often pain and sort of pelvic pain. Though I acknowledge that the huge amount of people with endometriosis have problematic periods, so that's why it's included in the classification system, but it's in this section. I don't think it really matters where it goes as long as it's in there. But it also sits alongside those slightly rarer causes. So anismocele is like a little outpouching after a cesarean section in the scar that can cause a lot of spotting. It's unusual, but we do see it sometimes. And you can get abnormalities in the blood vessels that can cause really heavy bleeding. So those things would all be in that other category. And I think it's wise to have a category to pick up not only these things but other things that may be added in the future. And this is hopefully going to be a working sort of system that will develop over time as our research and knowledge of these conditions increases. But these non-structural causes, I think, are probably much more likely to be amenable to the medical therapies that we've got. And again, I hope I've highlighted, I've gone through here, why we need to know which condition that people have or which underlying cause people have, so we can start to direct the treatment so people aren't going through one after the other, and we can get a bit more clever about using them. Some of our treatments are excellent if they're used in the right people at the right time. But I guess for the last bit of the talk, and I think hopefully we'll have lots of time for questions and discussion. So it's just the last few slides. I'm just going to give you an overview of what we're trying to do in the lab. And I love this saying, the electric light bulb did not come from the continuous improvement of candles. We could tweak and tweak and tweak at our hormonal treatments, but I wonder if we need to start thinking differently about things and start looking for the underlying cause and specifically directing treatments to that, to give people the opportunity to have non-hormonal treatments or treatments that they only use during menstruation rather than right the way throughout the menstrual cycle. So that's what we're trying to work on in the lab. And we use a combination of techniques for this. The people coming to my clinic are incredibly generous with allowing us to take, if they're having a biopsy of the lining of the womb, allowing us to take any extra that's left over to the lab to do some research. We also use some mouse models of menstruation to sort of investigate these problems. And to summarise, 3 or 4 years of work into 2 short minutes, we know that progesterone is withdrawn at the late secretory phase of the cycle that is the trigger for menstruation. I've told you already, there's a big inflammatory response. The blood vessels need to narrow. You need to have this low oxygen level in the lining of the womb to then trigger the repair process before it goes on into the next cycle. So we know that this is what happens physiologically at the time of a period. And we looked at heavy menstrual bleeding and found that when progesterone is withdrawn, you get the inflammation, it's maybe increased, but we don't tend to see the same blood vessel narrowing. We definitely don't detect the same amount of hypoxia or really low oxygen levels in the endometrium of people with heavy periods versus those with normal periods. And this delays the repair process. So people with heavy bleeding not only are losing more, but also bleeding for longer. So they tend to have more blood loss and more days of bleeding, so it's sort of doubly compounding the problem. So we did some work looking at a medication that can, I guess, trick the lining of the womb into thinking it's got very low oxygen levels even when it hasn't. And we've shown that that completely rescued the repair process. So we're hopeful that this medication, which we have used in mice at the moment, but we're hopeful that this medication may be very helpful for women with problematic periods. And my real hope is, I think it shows promise as a treatment that people would take just at the time of a period and it doesn't have hormonal side effects. So I hope I've gone through the objectives and it's sort of given you some definitions of typical menstruation, of what may constitute problematic menstruation, and some of the strategies that we use medically to try and document and sort of convey these kind of problems that people are experiencing on a day-to-day basis in a standardized way that then can be used for research right across the globe. I've spoken a bit about what we currently do and some of the problems with what we currently do, and then I hope that I've convinced you that by making a diagnosis of the root cause of the bleeding problems, that then we can improve the treatments and our use of current treatments, And then I've given you a bit of an insight into some of the things that we're doing in the lab to try and improve treatments of the future, to get new treatments into our armoury when people present in clinic, because it's really about patient choice and getting effective, acceptable treatments for people. I just wanted to highlight our menstrual health website, which we've tried to put together to have some reliable information about menstruation. It has some of our information about the research that we're currently doing, and some patient information about different treatment options that are offered if people come to menstrual disorders clinics. It's not fully developed, we're still a work in progress, but if any of the resources on there are useful, and we've tried to link to other websites, so if there's any links that are missing or any that you'd like me to put on, please do get in touch. And if there's any information on there that you would find would be helpful, some videos and some other information, please do feel free to share them and use them. I'd like it to reach the people that it really needs to. And this was in a collaboration between the Young Academy of Scotland, NHS Lothian and the University of Edinburgh. Also, very cheekily, I'm just putting a little ad for our Future of Reproductive Health meeting that we're holding in Edinburgh on the 1st and 2nd of March. It probably will be more of interest to those with a sort of more biomedical background, but I'm very aware that, you all need to work together. So if people have an interest who are not from that kind of field, please do feel free to take a look at the programme and come along if you feel it would be useful. The abstract deadline is on Friday, so please do put an abstract in. It doesn't need to be a complete body of work. It's really aimed at early to mid-career researchers with a lot of career development aspects to it as well. So take a look at the programme and please do come along if you feel it would be useful. And that just leaves me to thank everybody that I work with, the students, the members of staff, the clinical colleagues, the laboratory colleagues. It's really them who makes doing this so much fun. I'd like to thank all of the people who take part in our studies. We couldn't do any of it without the patients very altruistically giving us some of their tissue samples to work with. And I thank Hologic for the images that they've let me use in the presentation, and the funding bodies who've very kindly given us the finance to get on with some of this work. Thanks very much. I'm very happy to answer any questions.
Very much, Jackie. That was fantastic. I think it's really important for us, thinking about this from more of a kind of mental health point of view, to really think about the some of the more kind of medical and biological aspects of menstrual health. So yeah, that was really enlightening. Any questions in the room? I'll try and get the. Yep, Joe.
Thank you so much for your talk. That was fantastic. It was great to go have that kind of broad overview of everything as well. I'm a GP in Bristol, and when women come to me with heavy bleeding, obviously one of the management options, as you mentioned, the Mirena, and obviously other hormonal contraceptives. But one of the main reasons that women will give to me to say in response saying they wouldn't want that contraception is not normally fertility, it's sometimes the side effects of those hormonal contraceptives. So specifically, there seems to be a group of women who are very progestogen sensitive. So they feel it really affects their mental health significantly. And I'm just wondering how clinically you might identify those women yourself, but also where's the research on those women, and how do we predict which women are going to have those mental health side effects?
Yeah, it's a good question. I hear these things all the time in clinic. I mean, what we need is a good alternative, and we don't have one. So we've got tranexamic acid and non-steroidal anti-inflammatories, and that's it, or surgery. So it's very difficult as a GP, I would imagine, not being able to offer surgery, and your hands are tied. So that's why I think you've articulated the very reason why we need to do the research to get the better treatments that are non-hormonal. I mean, you could do a lot of research to predict who's going to get those things, but to be honest, the most predictive thing, I think, is how they've responded previously. And most of these women have tried the pill in the past, and if they've had a bad experience with it, I can completely understand why they don't want to do that again. And at the minute, whereas the conversations I'm having with people is, my periods are so bad that I'm willing to give this a try again. Which is it's hard to take on, right? And you sort of think, well, what's your support network? If your mood goes down, what are you going to do? Blah blah blah. So these conversations are tricky. I mean, you may find that a sort of lower dose coil might be better. One of the JDAS coils. It's licensed for contraception, right? But it will help with the bleeding profile. It doesn't give endometrial protection. But that's perhaps worth a try using some of the lower dose ones to see if that helps, if there's no contraindication and you can be using it for contraception.
And clinically, do you find that people who have responded poorly to maybe the combined or the progestin only pill respond better to the Mirena or are less likely to get those progestin?
Yeah, so it's I mean, some of it will go systemically, right? So some people, I find some people are okay with it, and other people aren't. It's I think if somebody said, "Oh, I was fine with the pill," they're likely to be fine with the Mirena. So that's easy. So it's the group of people who have had real problems in the past. I'm just really honest with them and say, well, you can try it. On the proviso that if you find your mood is getting really low, that we take it out again. But it's quite an expensive thing to put in if they're not going to, if it's not going to work. So it would be lovely to have some way to predict who is going to be okay with it and who isn't. I think the prediction is probably based on their past history. I think, yeah, I mean, it would be lovely to predict who is and who isn't, but we would still need a non-hormonal contraceptive alternative. And if we had a good one, or non-hormonal treatment alternative, and if we had a good one, anybody who said I've been sensitive in the past, we would just use that. So I've sort of focused on that, thinking, yeah, I mean, it'd be great to predict it, and there's a lot of work going on trying to predict contraceptive-induced menstrual changes, and all the different ways that we could perhaps do that. And do a screen for who's going to respond best to which contraceptive. I mean, that would all be amazing, wouldn't it? But I think for this heavy bleeding issue, I think we just need a really good non-hormonal alternative. It would kind of solve that problem. But until that comes in, I think we just have to be open and honest with people.
Okay, thank you.
Thank you. Any other questions in the room? We've had a few come in on. Yeah, Alex?
I was just thinking, I mean, I don't know the proper facts and figures about this, but I think from what I've seen, there tends to be quite a long period between the onset of symptoms for sort of problematic bleeding and actually having something diagnosed. Like if you had, say, endometriosis, I think there's quite a few years on average that it takes someone to get diagnosed. What do you think, if you have any opinions on this, needs to happen for that to sort of that gap to be closed and to get people diagnosed quicker?
Yeah, I mean, I think this is something that the campaigners around endometriosis have been really great at highlighting, this sort of 10 years to getting a diagnosis of endometriosis. I mean, I don't know what it's like for abnormal bleeding, but the people, I run behind in clinic all the time because the first 10 minutes of the consultation are people crying because I'm the first person that's ever believed them. And it is really tricky. These people have been dealing with this for 10, 15 years plus often. And I don't know how I think it needs to be highlighted. I think we all need to talk more about what's normal and what's not normal. I think people talk within families, but clearly there's a genetic and familial component to this. So if your mum's had heavy periods and you have heavy periods, then that normalizes heavy periods. And I see them coming in with a hemoglobin of 60 and needing blood transfusion. And they say to me, but I thought that was normal. I mean, that's not normal. So it's having these kind of outside family conversations, I think, is going to be quite useful. And I think the generation coming up now are much more vocal about it. So I think things probably will change over time, and things are changing in that way for the better. But it's a society thing as well as a medical thing, isn't it? It's not just that they're not being diagnosed, they're not presenting. So I think we need to tackle this from a number of different angles.
Yeah,
hello, Jackie. Thanks so much for actually introducing me to the 4M Consortium. I'm just curious, so when women do come up to you who have pre-existing mental health conditions, and if you are kind of forced to prescribe something that might debilitate them further, as a normal practice, would you also ask them to get psychological support in parallel? Would that be a normal practice?
Yeah, well, I think probably. So if they've got pre-existing sort of mental health issues, they're often in touch with those services anyway. So it might be just, I mean, sometimes it's sort of keeping everybody in the loop, and saying to the woman, I'll drop a note next to your mental health team to say what we have been doing and share that information with them so that everybody is joined up. Sometimes that's a useful thing to do. I think. I think for me, on a sort of practical note, it's assessing the person in front of you and assessing their social supports. So if they've got a supportive partner and they've an awareness of their mental health issues and they've been very good at managing that in the past, then I know that they're likely to be proactive and if because it can make it better, right? We just it could make things better if they're not hosing all over the floor every month. I mean, that can have a really positive benefit in your mental health. So I think if somebody's got autonomy and support within their family, I'm much more reassured about that. I think if they don't have the social network surrounding them, then that's a bit of a more difficult decision, and I would spend a bit more time with them going through the pros and cons of each method. And if there really is no support, then I think you can't use the hormonal preparations. If you think you're going to have a detrimental impact on their mental health, then that's not, I mean, that's a contraindication in my eyes.
Yeah, I think that really speaks to the kind of biopsychosocial factors that we're trying to consider within 4M and that kind of approach. So, yeah. Any other questions in the room? Luana, should we go through the questions we've had? We've had a few online.
We can just read them out.
Yeah.
So I hope everyone can hear me. But so the first question from Sally is, so she knows about, so I'll just say how she's written it. So I know about the PALM Coin criteria because I'm a researcher with the luxury of time to keep up with clinical developments. However, I fear many GPs have not heard about this. I hear from lots of people who have been dismissed, misdiagnosed, mistreated treated with inappropriate medications and devices. So how do we improve the translation of such great research, clinical research guidance to GP practice?
Mm-hmm. So yesterday I gave a presentation to the Royal College of General Practitioners Hot Topics session on menstrual problems. So it's communicating this kind of thing to general practitioners. So there's educational opportunities like that I think we have to take advantage of as menstrual health researchers. And I think GPs in the main are excellent. There's a few that maybe aren't so great or so good at the menstrual health aspects. But it's I think in general they're trying to do a very difficult job under a huge amount of pressure. So they don't have the luxury of sometimes making the clinical diagnosis that I would have, but then it's about being joined up and saying, if you've tried a couple of things, instead of just persisting, please refer them into me. So it's keeping those channels of communication open between primary and secondary care from a medical perspective. So I think there's lots of things that we can do to sort of keep people up to date and try and work through this. I wouldn't expect my general practitioner colleagues to have an amazing grasp of the PAM coin system. I expect them to maybe be aware of it and know that you need to look for the underlying cause, but then they should be referring into me if the initial treatments aren't working. It's my responsibility as a gynecologist to improve the diagnosis of that kind of thing. So it's about translating between the two specialties, because I don't know everything a GP knows, and they won't know the same stuff as I would about the gynecology system unless somebody's got a real particular interest in it. So it's just about making sure that the patient journey is joined up and that we're as seamless as possible with that.
Cool. So next question's from Mary. So she says she's interested in how the new medication developed that you mentioned at the end helps with the repair by tricking the endometrium that there are low oxygen levels. If it's the low oxygen levels that are needed to help with the repair rather than the tricking of the body. And she says she found that really interesting, whether she's not got a medical background. So I'm not sure, I'm not 100% sure what she's trying to ask, to be honest. I think she's just wondering what the mechanism of the new medication helps with the repair if it is the low oxygen levels that are what
Yeah,
trigger
yeah,
the
yeah.
repair process?
Yeah, the question probably comes from the fact that I've you know tried to condense lots and lots of work into a very short space of time. So thank you for your question. It's very insightful. So what the low oxygen levels do is that they stabilize a sort of protein within the lining of the womb that then sort of tells the womb to produce a whole lot of repair factors. So the low oxygen levels are needed for that protein to be present. So the medication that we use makes that protein present even when there are higher oxygen levels, so that repair process still gets kick-started. I hope that answers your question. Yeah, it's very difficult to explain in a very short space of time. If you're interested, the paper's published. If you look up my name, and I think it was in 2018, the whole sort of paper's available. So you're very welcome to have a read of that if you're interested.
So next one is, do you have any findings with problematic periods and neurodiversity such as autism and ADHD?
Yeah. So I have a PhD student who's working on menstruation and menarche, and in those with neurodiversity. I think there's a huge number of very specific issues with that population that varies from person to person as well. I think. I see, I mean, these things are very common. So I see a proportion of people coming through my clinic with neurodiversity, and you know they need things explained in a slightly different way, in a slightly different manner. But I don't know if the underlying cause is different in those populations. I think the way that we treat it and manage it is possibly different. I would love to be proven wrong if that's the case. It would be really interesting if there was different underlying cause, but I suspect it's the same underlying causes that we need to manage in a slightly different way to tailor it to different people.
There's still more questions, so I'll just keep going. So another question from Sally. It would also be good to educate menstruators about iron deficiency and anemia, as not enough of us realise that it can worsen bleeding and other cyclical symptoms.
Yeah, so that's an excellent point. I mean, I think it's one of the very common causes of iron deficiency in women is menstrual problems. And do you know, it's not only that it changes things across the cycle, but if you're going into pregnancy with a low iron level, we know that causes a huge amount of problems obstetrically, right throughout the pregnancy journey and further. So I mean, the knock-on impact of having low iron levels is huge. You know, we see even in sort of gynecology practice, if somebody's entering an operation with low iron levels, they're likely to have more complications at the other end with the recovery. So, I mean, it has an impact on so many things that I think it's something that should be sort of spoken about more, because if people are walking around with suboptimal iron levels because of their menstruation, that is usually addressable. And could have huge public health benefits, yeah.
Last question from online. So in terms of diagnosing the underlying cause of menstrual problems, would you offer everyone an ultrasound, and when would you offer a hysteroscopy? The NICE guidelines are a little unclear on how you would determine offering a hysteroscopy.
Yeah. So yeah, so there's been a lot of chat about these NICE guidelines and hysteroscopy, hasn't there? I think I just take it down to the person sitting in front of me. So I think what I would do as a gynecologist in secondary care is I would probably get an ultrasound in everyone, right? So your GP's not going to be able to do that, and let's be honest, we're going to completely overload the NHS if we got absolutely everybody who walked through the door an ultrasound scan, and that's the reality of the scenario, unfortunately, at the moment. My view on this is that people should have an ultrasound scan if it is on history, so asking them questions and doing an examination. If you think they've got a structural cause, which can be determined in most people by asking them some questions and doing an examination, then they should have an ultrasound scan. Or if you start first line medical treatment and it doesn't work, then you might need to consider an ultrasound scan at that point. So it's a little bit, I mean, I think it's very hard for me to sort of advise my GP colleagues about when and when they shouldn't do ultrasound scans, because I have the delight of working in secondary care and having access to these things much more easily. Hysteroscopy, I think I've seen terrible complications with hysteroscopy. So you don't want to do any medical procedure without there being a good indication for it. So I don't think everyone should have a hysteroscopy. I think it's really important if somebody has fibroids that are distorting the endometrial cavity that they have a hysteroscopy to put in a marina, for example, if they choose that, because I think you're much more likely to perforate the uterus in somebody with large fibroids putting a marina in. So I wouldn't be advising that in any way in general practice. And if somebody has fibroids, I don't do it in clinic, I do it under hysteroscopic guidance. There are lots of indications for hysteroscopy to help with diagnosis. So that's looking with the camera, so you can diagnose polyps, you can diagnose submucosal fibroids. All of these things I think are really important and really good use of hysteroscopy. But in somebody, you know, with no structural abnormalities, I don't think they necessarily need a hysteroscopy to make a diagnosis. I don't think it's necessary. I don't think it's adding too much.
Great, thank you. If there aren't any more questions in the room, then I think that brings us very nicely on time to the end. Thank you very much, Jackie. That was really fantastic. And yeah, so I guess this is the 4M seminar series officially launched, and we'll hopefully have another one soon. So yeah, to the people online, do follow us on Twitter and sort of see how we're getting on, and we'll be advertising all of our seminars on there. And thank you very much for signing up for this one, and thank you again to Jackie for speaking to us today.